Good afternoon, everyone. Presenting my paper on juvenile double seronegative myasthenia gravis, decoding diagnostic dilemma. Myasthenia gravis is an autoimmune disease which is usually caused by autoantibodies against acetylcholine receptor and the MuSK antibodies. But there are certain myasthenia gravis patients who do not have both of these antibodies, and they are said to be double seronegative myasthenia gravis. These are probably due to the newer antibodies which contribute to their double seronegativity. But what happens is there is a delay in diagnosis, and that may result in delay in treatment initiation. So the objective of this paper was to describe clinical features, serological profile and response to neurophysiological tests in children who are suffering with double seronegative juvenile myasthenia gravis. This was a cross-sectional retrospective analysis of all the children who presented to us with fluctuating muscle weakness and fatigability which fitted with myasthenia gravis clinical diagnosis. They underwent a laboratory assessment of acetylcholine receptor antibodies and MuSK antibodies. Those who turned out to be negative for both of these antibodies were termed as double seronegative, and they underwent neurophysiological tests in the form of repetitive nerve stimulation and the extended antibody assessment of LRP4, ASK and cortactin antibodies. Who did not have serum antibody dosage performed were taken for exclusive criteria. At 18 months follow-up, we assessed the patient with the help of Myasthenia gravis composite scale. The outcomes were termed as adequate response if there is more than 3-point fall in the Myasthenia gravis composite scale, and partial response if there is less than 3-point fall, or refractory response when there is no improvement even with corticosteroids. There were, of the total 52 children who had myasthenia gravis symptoms, 8 patients were double seronegative, amounting to 15%. The mean age was 12 years and the female ratio was preponderance. Of the total 8 double seronegative myasthenia gravis, 3 were positive for LRP4, 2 were positive for cortactin antibodies and 3 were inconclusive. All of them had a myasthenia gravis composite score of 3 to 4, showing that they were mainly ocular symptoms, and the treatment was perfectly adequate in LRP4 antibody positive children, whereas immunosuppressants were required in cortactin antibody. Of all the children who were subjected to repetitive nerve stimulation test, 5 children were positive and 3 children were negative, who then turned out to be positive for single fiber electromyography. So why does double seronegative children becomes important? This was a child who was operated for intermittent exotropia, later referred when he developed a diurnal variation of the ptosis after about 6 months following intermittent exotropia surgery. And IcePac was positive of an extended antibody assay, turned out to be positive for LRP4 antibody. So the children who have intermittent XTs or fluctuating diplopia, when they are double seronegative and negative for both RNST, they can be confusing and can be treated by surgery unknowingly. So the discussion is 15% of generalized myasthenia gravis and 50% of patients with double ocular forms are positive for double seronegativity. But the previous studies were done only in adults. So in our study, we studied double seronegativity in children because that is where double seronegativity is more common and they mainly present with ocular symptoms. So we ophthalmologist may be the first contact doctor in most of the double seronegative juvenile myasthenia gravis. So high index of suspicion should be positive from our side. The most common autoantibody found is LRP4 autoantibodies, and this is in concordance with the previous studies too. The prognosis is excellent with LRP4 antibody. Those children who had cortactin antibody, they needed immunosuppressants as an additional therapy, and the single fiber electromyography is more sensitive than repetitive nerve stimulation test in all of these double seronegative children. So conclusion, a successful myasthenia gravis treatment requires an early diagnosis. In case of double seronegativity, this early diagnosis is hindered because of normal antibodies being absent. So we have to use a cocktail tests of clinical, serological and electrophysiological test, put all of these together with a high index of suspicion. When we adhere to the treatment guidelines of myasthenia gravis, despite double seronegativity in children, prognosis remains excellent. These are my references, and remember, suspicion, always suspect the unlikely. Thank you.
In how many cases did you do penicillin test?
Tensilon test was done only in 5 cases because they are children, sir. Usually it's comparatively difficult and a bit of more risky in case of children. So we did a combination of clinical assessment, serological, as well as the neurophysiological assessment in all of these children.
Is acetylcholine mimetic or mimetic?
Presmimetics.
Mimetic.
Mimetic.
You see, the acetylcholine is easily destroyed by it doesn't remain in the body. It is destroyed by the cholinesterase.
Yes.
If you got a stuff like anticholinesterase, you preserve the acetylcholine. What are the other forms causes of the ptosis?
Other?
You see, it does cause ptosis.
Yes, sir.
You have a simple ptosis associated with the deformative leads ptosis. Ptosis associated with the synchronic movements of jaw leads ptosis. Ptosis associated with the varying degrees of extraophthalmoplegia. You have got a sympathetic ptosis, which is associated with congenital sympathetic pulses. You have got a periodic ptosis, cyclooculomotor syndrome. You have got an intermittent pseudotosis associated with Down's reduction syndrome. If you remember this classification, it's very good. Thank you very much.
Thank you, sir. Thank you, ma'am. Yes.
Did you test for, did you do a CT test for thymoma?
CT test was done in nearly 70% of the children who could afford for it, and most of them were thymoma negative in these cases, ma'am. So none of them had any need for thymectomy in these children, so I did not include it as a part of the line, but 70% of the children underwent CT test for the assessment of thymoma.
And the medication that you gave was, what was the medication given?
Ma'am, when they came to us only with ocular symptoms, the pediatric neurologist initially started with pyridostigmine. But if they were going to them initially with both ocular as well as systemic, then he started a cocktail of pyridostigmine with corticosteroids. In our ocular symptom, children with only predominantly ocular, he assessed for a period of 4 weeks, 1 mg per kg for about 4 QID dosage if he felt still maybe from our side the movements are not resolved or the ptosis is not resolved. In those situations, they added a step up of corticosteroids. Later, based on our inference as to how the child is responding, he did taper the pyridostigmine, but then the tapering of the corticosteroids has taken quite a bit of time in most of these double seronegative cases. It has been continued in a small dosage for up till 1 year to 1.5 years in children. There were those with cortactin positive. One child still did not show improvement with steroids, and azathioprine was started in that child, and he's showing a good treatment with azathioprine, but still he is on azathioprine, and the corticosteroid also is continued in a very small dose in that child till now, which will be tapered over the period of next another 6 to 7 months, ma'am.
Did you use neostigmine substitutes?
Pyridostigmine has been used, sir. Yes, that's the first line of the management.
Any recurrence after stopping the medication?
Till now, none of these children have shown any recurrence, but only 2 children have been completely tapered off the pyridostigmine and corticosteroids till date. The rest of the 6 are still being continued, so the stopping part in these children is taking a bit of extra time as compared to those who were acetylcholine receptor positive children. They have shown a good prognosis as compared to these kids in whom a longer dose is required for the treatment part.
How much is your follow-up till now?
Till now, the statistical analysis was done at 18 months, but right now I have finished 2.5 years of follow-up with most of these children, ma'am.
And what is the common age range in your study? Means most
from around, children? If we take a range, it is about 8 to 16 years of age. The mean has come at around 12 years, madam.
Okay.
Very good.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you very much.